Good morning, everyone, for this presentation on videolaryngoscopy. Is it the standard for intubation? As you can see next to the email address, there is a Twitter handle. So most of the new information or the advancement, technological advancement, particularly in the field of anesthesia, I usually get the updates on Twitter. Take this opportunity to urge everyone to be active on Twitter because it's a one of the greatest source of latest information. So basically, as Sujit sir has said, the technology of video laryngoscope is just couple of decades old. But in last 2 decades only, there has been tremendous development in the field of video laryngoscopy, meaning that we have got at least now 20-25 different kinds of video laryngoscopes. The video laryngoscopes can be broadly divided into two categories. One is a channeled one, in which there is a dedicated channel through which the endotracheal tube can pass, and there is a screen on the top of it, or you can have a bigger screen if you can attach it. So the important ones in clinical use are usually by the King Vision, the Pentax AWS, and AirTrack. So these are having this dedicated channel, as you can see it here. The non-channeled one are again divided into two different categories. One which has got a Magrath kind of blade, that is our routine routine laryngoscope blades, and to which a camera is attached and it is displayed on the screen. This can be a Magrath type of video laryngoscope, or there are some hyper angulated blades which are available. So these are called as HAVL, hyper angulated video laryngoscopes. So there are actually different learning curves for all these different kinds of video laryngoscopes. Because we are very much used to this kind of Magrath blade, a learning curve is probably shortest for those who have got. So this is a Make in India Medicam video laryngoscope, which I have been using since last 4 or 5 years. I won't be dealing much on the theory part of it. So much of it is about the evidence. So what is the evidence that video laryngoscopy is for the intubation? And it can be intubation in the operating theater, or it can be intubation in the ICU. This year's anesthesia and analgesia, there was this very good pro and con debate whether the video laryngoscopy should be standard of care. So if you say standard of care, then it has got a lot of meaning, in the sense that it is intended to be rigidly applied. That means it is standard of care and it should be followed in virtually all cases. And it's a very strong term because it has got legal implications, meaning that if it is a standard of care and if you don't have it, then you are a defaulter. So then there are guidelines. Guidelines are intended to be more flexible, and it should be followed in most of the cases, if not all. And options, meaning that it is neutral with respect to recommending use of interventions. So it is desirable to have it. So we will see in following 15-20 slides whether the video laryngoscope is now standard, whether it has found any place in the guidelines, and whether it's an optional thing to have in your armamentarium of intubation. This is an excellent study which is published in BJ last year, in which what they have done is they have seen two hospitals, and one hospital they have said that it's a compliant hospital, meaning that they studied around maybe 22,000 different patients. uh, uh, 10,000 in the compliant hospital group, large teaching hospital, and another one is a non-compliant hospital, meaning that they implemented a quality improvement project for almost a year in the entire department. And they saw, for what happens in the pre-intervention group, quality improvement was in the term of teaching video laryngoscopy skills to the faculty, then to the fellows, and then to the paramedical staff. So what they saw, that the use of video laryngoscope in the implementation has increased to almost 95%. So 95% of first attempt intubation were seen in the post-intervention group. And if you see, proportion of easy airways, meaning that uneventful intubation, first attempt intubation, it was around 90% in the pre-intervention group, 92% group. And with the help of videolaryngoscope, it was almost touching to 98 to 99%. And it was statistically significant. Means if you systematically implement videolaryngoscopy as a quality improvement project, the proportion of easy airways has significantly improved from 90 to 92% to around 98 to 99%. And what happened in a non-compliant hospital group, the use of videolaryngoscopy remained very on the lower side, even with and there was no quality improvement project. So they were given a choice, whatever you want to do. Okay, and first attempt and videolaryngoscope was used in very less number of patients. And as you can see, their proportion of easy airway was on the same range pre-intervention phase, that was around 92 to 93%, and it remained almost the same throughout. Means there was no difference in whatever they were doing pre-intervention has remained the same in the post-intervention phase, meaning that there was no major change. While in the compliant hospital, which learned new skills and they implemented videolaryngoscopy as their primary tool for intubation, the easy airway increased proportionately, and first attempt intubation also improved significantly. So this is again represented same way. So proportion of increased airway increased by 4.4%, meaning that almost 5% improvement was seen in the compliant hospital, and it remained almost the same in the non-compliant hospital. So using videolaryngoscope as a systematic approach definitely helps. So from here on, there were a lot of editorials which is published in BJA and our Indian Journal of Anesthesia, even by Dr. Diwatiya sir, saying that should we use videolaryngoscopy as the only tool or as the universal videolaryngoscopy approach, was they say. And there was again a question mark whether a direct laryngoscopy is obsolete or not. So we will see for the evidence. But before moving on to the evidence, personally using videolaryngoscope for last 3 or 4 years, the biggest change in the intubation that with the use of videolaryngoscopy that I can see is we have changed from me to we. Meaning that if you are using videolaryngoscope in the operating theater, okay, so definitely everybody is engaged in the airway, and everybody can see what you are trying to do as an as the person who is intubating. I remember the residency day when the resident is intubating with the routine laryngoscope, and everybody around him is jumping. Are kai distay tula, kai distay sang. And that very moment, that person goes in deep meditation, and he just doesn't speak anything, and everybody starts yelling on, "Are patkan sang, kai distay patkan." So this has definitely changed with the videolaryngoscope, and everybody, including the technician and at times even the surgeons, they get engaged in the intubation, saying that okay, chan distay ata, patkan chala washo. So it is that important thing. So I think this is a major cultural shift which has happened with the videolaryngoscope. So coming to the evidence proper. So if you see for the evidence, this is the biggest paper or a Cochrane systematic review, which has been published last year in BJA. So they have studied almost every single paper which was published before 2022 for this evidence of videolaryngoscopy versus direct laryngoscopy for adults undergoing tracheal intubation. So they saw for various parameters, because not every study will document everything, but they saw that certain critical outcomes are very, very important. So they labeled these 4 outcomes as the critical outcomes, which are failed intubation, which is defined as more than 3 attempts or change in device or intubator required. So that is a failed intubation. So they defined second important critical outcome as hypoxemia, that is defined as oxygen saturation below 94% between start of induction and recovery of anesthesia. So incidence of hypoxemia. Third important critical outcome is first attempt successful tracheal intubation. This is with the preamble that if you intubate in the first attempt, the number of injuries, the number of adverse reactions or adverse outcomes are very low if you can successfully intubate in the first attempt. And the fourth and most important, another important critical outcome is incidence of esophageal intubation. Okay, so those were the critical outcomes. So apart from that, they have studied other important outcomes. So they are not critical, but they are important in the sense that dental trauma or time for tracheal intubation or Cormack-Lehan grade, or for that matter, percentage of glottic opening. So this was the new term which was introduced after videolaryngoscopy came into picture. So how much percentage of glottic opening you could see. Then patient reported sore throat or number of attempts. So more the numbers, obviously, more the adverse reactions. Intubation difficulty scales were developed, and it was seen with these intubation difficulty scales. And in general, mortality within 30 days of intubation, which is very, very rare nowadays, but still they studied this as an important outcome measure. So let's see what they found. So they divided it into various categories. Like they saw the evidence for hyperangulated videolaryngoscope versus direct laryngoscope, or a channeled videolaryngoscope versus direct laryngoscope. And obviously the largest pool of evidence was for the Macintosh type of videolaryngoscope, which is the commonest one being used in clinical practice. So we'll see them one by one. For the failed intubation, there were more than 4,500 patients being studied in more than 40 studies. And they have very clearly said that the relative risk of failed intubation clearly favors videolaryngoscope, and this is a moderate certainty evidence. So moderate certainty still does not come into 1A recommendation. So we are still not having the exact evidence, but still it clearly is in the favor of videolaryngoscope. So what happens for incidence of hypoxemia? So it was studied in 16 different studies with more than 2,000 patients, and relative risk comes down for the hypoxia with the use of videolaryngoscope. And again, this was a moderate certainty evidence. Successful first attempt intubation was the commonest endpoint for many studies, and there were more than 7,000 patients which were studied in more than 43 studies actually. And there was very clear again moderate certainty or very clear favoring videolaryngoscope evidence was found. So first three, and then coming to the fourth one. So esophageal intubation, incidence of esophageal intubation significantly reduced with the help of videolaryngoscope, but this was a low certainty evidence. So all the critical parameters, if you see, failed intubation, hypoxemia, successful first intubation, and reduced incidence of esophageal intubation, all four were favoring the videolaryngoscope. So most of this study actually they had enrolled patients who had got an anticipated difficult airway, or they were it was said the studies were criticized, that was studied that they do not represent the clinical scenario of the real life. So they are either anticipated difficult intubation or for the novices or only for the expert. So this particular study, which was a multi-center randomized study, which was done in 4 different centers of Germany, which included more than 2,000 patients, and they included patients without any predicted difficult airway. So all routine patients in whom you had not predicted, the clinician had not predicted the difficult airway. And in that study, the first attempt intubation was significantly high with McGrath videolaryngoscope, the time, tracheal intubation time, there was always a criticizing point that if you use videolaryngoscopy, it takes more time for intubation. But this particular study did not find any difference in the time required for intubation. So if you overcome that initial brief period of learning curve, then the time required for intubation is also not very different, and definitely not clinically significant for intubation time. So this evidence is very, very clearly favoring the videolaryngoscope. So what about using other tubes like double lumen tube in thoracic surgery? So this meta-analysis again said that first attempt placement of the double lumen tube, videolaryngoscope has provided higher success rate. So with the use of videolaryngoscope, there was lower incidence of oral, mucosal, and dental injuries. With the double lumen tube, there is very high incidence of post-operative sore throat because the tube is very bulky and there is a lot of airway handling which happens during placement of double lumen. The author saw for the evidence of this post-operative sore throat as well, and this was again significantly reduced in videolaryngoscopic group. And again, as for the single lumen tube, there was no significant difference in intubation time required for the double lumen tube. So all in all, all critical outcomes, all the important outcomes have very clearly said that videolaryngoscopy use is associated with better outcomes. After all this evidence, has it find place in the guidelines? That is very important, because unless the evidence gets accumulated for 4 or 5 years and then it gets translated into guidelines. So this ASA difficult airway guidelines were published last year, actually an update of the previous one. I think the previous one were published in 2016, and in this they have published this meta-analysis summary, and in which the laryngoscopic view, successful intubation, first pass success, so all these parameters, if you see, are significantly improved with the help of videolaryngoscopy. So they what the guidelines has said, that in airway management after induction of anesthesia, so after you induce, you are able to ventilate this patient adequately, so you are in a non-emergency pathway. Okay, so in this case, if you can ventilate, but if you are unable to intubate, in this particular category, if you use alternative devices, and these alternative devices are definitely, they have said that videolaryngoscope has found a place in that algorithm at this place. So if you are unsuccessful with the first attempt but you are able to ventilate, then definitely you should consider videolaryngoscopy as an alternative device for intubation. There were these guidelines on universal management of airways, and international airway societies has formed for this preventing unrecognized esophageal intubation. So all of us know that exhaled CO2 or CO2 monitoring is the gold standard for confirming intubation or excluding esophageal intubation. And on the right there, on the second recommendation after that, is routine use of videolaryngoscopy. They have recommended whenever it was feasible. So coming to the second part of the intubation, that is in critically ill patients in ICU. So these patients, it is very, very crucial because these patients are critically ill. They have got very low reserve for the oxygen and they rapidly deteriorate. They might be on different supports like inotropic support, or they may be on CPAP, or they may be on CRRT and things like that. So it is very important that you safely and quickly intubate these patients. patients. And has the videolaryngoscope found any place there? So this was an initial study published some 6-7 years back, and they said that actually doing it with the videolaryngoscopy, a small study, but they have said that it doesn't make a big difference. The reasons probably which were given are that majority of the intubations were done by the fellows who were doing critical care management, and they said that the number of patients which were enrolled was not very sufficient. So this is a very landmark study actually published in NEGM a couple of months back by the name Device. So this was a device trial. So this was a multi-center study enrolling almost 2,000 patients across more than 20 centers in Europe and America. And this study actually was prematurely stopped because there was a very clear and clear difference in the first attempt successful intubation. And the difference is very clear, that 70% of them with the direct laryngoscope versus 85% of them with the videolaryngoscope. So this study was prematurely stopped because there is a very clear and stark difference in the outcome. So they said that videolaryngoscopy should be used whenever you find it, and this was true across all patient categories, meaning that if patient is obese or not obese, if there is a traumatic injury, if there is a traumatic injury, if there is anticipated difficult intubation, if the operator is a novice or an expert, or if the operator has not used videolaryngoscopy at all, or he has been trained properly in this. So all these categories actually have favored videolaryngoscopy doing better. But the other important outcomes, which was like severe complication during intubation, meaning that there is major airway trauma or uh, hemodynamic disturbances or use of vasopressors, it was not statistically different when videolaryngoscope was compared to the direct laryngoscopy. So all in all, in critically ill patients, so this landmark trial has very clearly demonstrated that first attempt intubation is more successful with videolaryngoscope across all patient categories. In a nutshell, if you want to see what all things if for pro videolaryngoscope as the standard of care, so the evidence is very clear that videolaryngoscope improves tracheal intubation success rate. It reduces the incidence of hypoxemia. It definitely reduces the esophageal intubation risk, which is a major criteria. So there is ease of intubation with the videolaryngoscope. And as there are a lot of companies which are coming up in competition, the earlier cost, which was there in the range of 8 to 10 lakh, has now significantly come down to almost 1 lakh category. You get a good, decent videolaryngoscope, if not the best. And it has got definitely advantage for teaching the trainees. But at the same time, those who are in teaching institute, they may argue that since beginning, if you teach them skills of videolaryngoscopy, they may lose skills of direct laryngoscopy. But there is again a debate, because if you see, when we started doing nerve blocks, slowly the incidence of using ultrasound guided nerve blocks increased. And it cannot be said that if you have got an ultrasound machine with you, still you would like to give it with the landmark, for the simple reason that there is now clear evidence and everybody will agree that use of ultrasound will definitely improve the success rate. It will give a demonstrative purposes and for documentation purposes. So for every point of view, ultrasound guided nerve blocks have an edge above the landmark guided or a peripheral nerve block, stimulation guided blocks. So so if it is available, you should definitely use it. So that is the present concept. Same thing about the ultrasound guided central line placement. So we all have been trained in using it by landmark technique, but since the advent of ultrasound, whenever there is difficulty, we immediately resort to doing the central line insertion with the ultrasound guidance. So same holds true for the video laryngoscope, I think. So whenever it is available, you should always use it. And so another point of the story is, if you have got video laryngoscope, that does not automatically guarantee that it will be universally successful. So there are lots of learning curves with the video laryngoscope as well, and you should always have a backup plan for the video laryngoscope as well. If it fails, what next? That you should be sure. And there are certain patients who still require flexible scope intubation. So if you can't insert a video laryngoscope, obviously you can't intubate that patient. So there are initial phases in which it may take little longer with the video laryngoscope, but as you slowly get acquainted to it, or your assistants, your technicians, if they get used to the steps of video laryngoscopy, I think the time required for intubation has come down. Is it still the standard? I think this still is in the orange zone. There is still we cannot say that video laryngoscopy is standard of care, because there are incidents of failed intubation with video laryngoscopy as well. But here I would like to quote an example of a case which was filed against intensivist in Hinduja hospital. What they patient had got some pleural effusion, and while doing a drainage of that pleural effusion, I think they damaged some structure, and there was a lot of bleeding, and patient collapsed and ultimately succumbed. So it was very clearly said, did you have ultrasound machine in your hospital? It was yes. So then why did not you use it? So I think same story can apply for video laryngoscope. So if there is an unrecognized esophageal intubation case, and if somebody asks you, did you have a video laryngoscope and did you use it? I think we are not justified in saying that, okay, we did not have the skills, or we did not, I'm not used to it. So I think every anesthesiologist should get used to video laryngoscope. And already, as we discussed, video laryngoscopy is finding a place in the guidelines, and definitely it's an option. So this dark green means definitely video laryngoscopy should be considered as an option in whenever it is available. So there are other uses of video laryngoscopy as well, as we use now routinely it for the Riles tube insertion. As you can see, esophageal opening is clearly seen, and Riles tube goes like anything. So we all know that putting Riles tube at times can be a big headache, and there is a lot of trauma, a lot of bleeding and things like that. But with the help of video laryngoscopy, you can definitely put it with ease. We recently published this paper on use of video laryngoscopy for T probe insertion. So this was a multi-center randomized study, and this video again says the similar thing for the Riles tube. We can very clearly see for the esophageal opening here, and a big transesophageal echo probe can be passed very easily and smoothly. And we demonstrated that the incidence of injuries is reduced to half with the help of video laryngoscopy. I'm very happy that particular paper was highlighted in the year in perioperative echocardiography in JCV. So how particularly how I have done it in my clinical practice in nutshell. So I started using video laryngoscopy in 2022, maybe 3 or 4 years from now, particularly during COVID times, because of the cost constraint maybe, or availability. I started with this Macintosh type of blade, which was made in India, not very expensive. Then there were initial hurdles, that you can see the vocal cords, but you can't pass the tube. The learning curve, you may have to withdraw the probes, certain maneuvers that definitely they help. But the need of bougie is still higher, and personally I keep very low threshold for use bougie for intubation. And particularly now the Portex tubes, since they are not available, so every hospital now procures different kind of tubes, and probably some of these tubes are very floppy and they have got no rigidity. So probably for those tubes as well, so we have to use bougie when we are using video laryngoscope. So presently I use video videolaryngoscopy for every single case. That is a universal videolaryngoscope. But from our group, some of the members are still hesitant and they use direct laryngoscope as Macintosh blades as the routine one. But whenever there is difficulty, every Ozone member is, I think, now well acquainted with video laryngoscopy skills, and we use it in whenever we have gotten anticipated difficult airway. Definitely we use it as the first approach, and it has definitely reduced the incidence of difficult airway in our practice. All our technicians are now very well versed with using the steps of video laryngoscopy, and they help us a lot. As I said, it has shifted from me to we, and we use it for other auxiliary uses like Rice tube insertion or TE probe insertion. And if you have to document, another important thing which I want to say, that if you want to document that there is injury or there is no injury, so after you remove the video laryngoscope, you can just do a scopy and document that there is no injury. So this is a very, you can just store a clip or take a picture. So that's a very, very important thing that you can do. Thank you.